Thank you, Josh, and thank you, all of you, for joining us. We're really delighted to share our experiences with supporting community to move away from commercial tobacco. I want to start just by sharing a bit about Sonoma County Indian Health. We're in Santa Rosa, California. We're about 60 miles north of San Francisco, and though we're considered rural, the main city in the county is about 150,000 people, a bit more. We're a 638 tribally run clinic, of course, supported by 7 tribes. 5 are distinct Pomo tribes, and then we have a Wapo and Miwok tribe. We're a full-service clinic, so we have medical, dental, behavioral health, nutrition, full pharmacy, about 170 staff, with a significant number of community members, Native folks that are employed here at SCIP, about 5,000 active patients, and many of our patients, of course, are California Indian, and a lot, because we're close to the Bay Area, a lot are from other tribes throughout the United States. I want to thank Chris Cooper, who's a health education specialist at California Rural Indian Health Board, for giving us this opportunity to present on the webinar, and he and our local health department supporting us through this process.
So why is commercial tobacco cessation so important? The Centers for Disease Control say that quitting commercial tobacco is one of the most important preventative health strategies available. Most people in the United States are dying of chronic illnesses, not infectious disease, and commercial tobacco is a major contributor to this. According to the CDC, almost 500,000 deaths per year are directly related to commercial tobacco usage. In the 2014 Surgeon General's report on health consequences of smoking, it states that smoking has caused an enormous avoidable public health tragedy. In addition to causing diseases of nearly all organs of the body, it also causes inflammation and impairs immune function, which can exacerbate chronic diseases such as diabetes and rheumatoid arthritis. Nationwide, 17.8% of all adults smoke, with a higher incidence of 26% among American Indians, with wide variation from state to state and tribe to tribe. The CDC also notes that secondhand smoke exposure has been causally associated with lung cancer, heart disease, sudden infant death syndrome, reproductive effects in women, such as premature birth and low birth weight, and an increased risk for strokes as well. Although there are 45 million smokers, through secondhand smoke, 126 million people are impacted. So as healthcare clinics, this is one of the most important health issues for us to be addressing.
I want us to start by sharing really the focus we've taken on differentiating between commercial and traditional tobacco. We've tried to keep that our frame throughout this process, and knowing that there's a lot of traditional knowledge about traditional tobacco within California, Indian tribes, and a lot of that knowledge has gone underground. But we think that regardless of how each tribe interacts with traditional tobacco today, we want to lead the community really towards a more traditional and sacred relationship and knowledge. And really notice that search for the sacred is often, commercial tobacco often takes the place of that search for the sacred. We know that, our relationship with traditional tobacco, our local plant being Nicotiana biglovi, was gathered wild. It still is, and it really is the one of our earliest crops that was traditionally cultivated. We've used it for ceremony, during Indian doctoring, for making offerings and general prayer, and it's important that we share that it's always been used as a conduit, and really needs to be treated as a sacred medicine and used with proper protocols. That it's powerfully spiritual, and is also a psychoactive substance. So that's the frame that we've tried to take throughout this process. So today we want to share with you our story. It really comes from concern from community about the effects of second and third hand smoke on our community members. We want to look at the thoughtful engagement assessment process that we tried to embark on. Look at a bit about our smoke-free policy and the development of that and the actual final policy. We'll share with you some employee and community trainings that we offered. also the group and individual interventions and services that we have been working on, and then the medical department protocol development. And we'll share a bit of our reflection, our lessons learned. And as Josh shared, these are our 3 learning objectives. We hope we can offer those to you. So the concern for this work really came from the community. Our beginning came from actually this quote shared by a staff member. How can we allow people to smoke around the clinic? Elders and children are walking right past them. We're supposed to be a health clinic and we just condone it. That came from a staff meeting, which really kicked off this project, and it had a few staff members. Actually, this one is from the community as well, Native community member, looking at how little we were doing to address the issue. We had a real culture of commercial tobacco. We had ashtrays in all the entryways. Again, this is end of 2007, early 2008. We had, staff smoking by the back door. We had our red road groups, often smoking in large numbers in the front entrance, maybe 20, 25 people before or after, sometimes during groups. Clients congregating in those areas to smoke. It was a really important social space that we tried to bring inward into the clinic and create more sort of communal space for connecting. But it was impacting health, and we really noticed we needed to make the changes. And so from that beginning conversation, we started to look at the engagement and assessment and really taking action, realizing that at that time we had virtually no services to address the issue. We had some screening and education in our medical department through the primary care visits, but it was very inconsistent. It was varied as to who was asked, what information and education was given to the patient, how it was documented, often wasn't documented. The known resources were varied. Often we'd have just one generic, maybe a couple generic pamphlets, and the statewide 1-800 number. So the CEO took real note of this and assigned a staff who created the Smoke-Free Committee. And this was a committee that was formed with clinicians, staff, community members. Obviously, we wanted to have smokers and non-smokers, and really to focus on not just the policy, but through that conversation realizing there's much more that needed to be done, and that it needed to be done in a really slow and steady process out of respect for the community. And we wanted not to vilify smokers, but to bring them into the conversation, into the change. And so a lot of the focus was on that second and third hand smoke that did kind of take away from that dynamic of vilifying folks that were smoking. So we then developed a 15-month plan. Again, it was very slow and steady change. It led up to the Great American Smokeout, which is a health observation. It's a third Thursday in November each year, and it's from the American Cancer Society, a quit date for folks that want to quit, or even folks that are kind of early contemplation and just want to quit for a day. So we had one 3 months into the 15-month plan that was smaller, and then a larger event at the end of 15 months. And then we embarked on an information campaign, really gathering information from the community and then offering it back to them. So we crafted a letter, I think it is one of your handouts, about the upcoming policy. We did some community assessments, really gathering a sense of what tobacco meant to community and what investment they had in the smoke-free environment policy. And then again, to share that information with the committee to help us to be thoughtful in our approaches. We had several lobby events. We'd offer giveaways and have conversations about commercial and traditional tobacco. We had a video that was made with some of our local folks here talking about their experiences in quitting commercial tobacco. We offered community education. I'll talk more about that in a moment. And as well, the committee realized pretty quickly that we needed to offer cessation services if we were going to put this policy into place, and I'll share more about that as well. And then we developed the policy and we shared the policy. It's important to note that we realized as we were moving through how to make this happen, we needed several champions, and preferably one from each of the departments to really hold space and keep the momentum and engagement from the community and staff. And really noticing now that we really just needed one person or maybe two to hold the structure and the program planning and implementation skills, and then needed many others to really, again, offer feedback about what would work with the community and to keep enthusiasm for the project. So we started just to get the buzz going and to kind of enliven the conversation. We started with general trainings within the community and with employees. So we had an all-staff meeting. Again, as you know, definitely probably about 150 people come to that. So we offered information there at our senior and elder center, and also with our POMO youth dance group. And the focus again was offering information around traditional versus commercial tobacco, focusing on the effects of second and third-hand smoke and how communities can make some changes around that. And then again, this need for the smoke-free policy. I find that all staff meetings really the best place to introduce new ideas into the community and get feedback, as well as we have a significant number of Native staff that work here at SCIP. And it's a great way to really disseminate information into the community, because if it's interesting enough, you know, it will get folks bringing it home and talking to their family members. And also it gives a chance for Native staff to give back their community, the knowledge they have of their own community. From these trainings, we started to gather folks that were interested in being a part of not just the committee, but a part of clinical training. So that's when we had Jean Farmer join us, and we had another public health nurse, some folks from our Wellbriety Red Road Circle that wanted to volunteer to be a part of it. And then Jean and I moved into developing the group and individual cessation interventions. So we looked at integrating really the skills and structure of the Freedom from Smoking curriculum from the American Lung Association, and then added the spirit and exercises of Second Wind, which is a California Rural Indian Health Board product, and it is in your resources list. So we used both of those curriculum to create our own 6-week group level cessation program. And we focused for several years on having, I guess 3 years, having one series per season. So we began that. We, along the way, added additional cultural adaptations. I'll share more about that. And later we added and have sustained an individual counseling clinic within the medical department that's 1 day per week. Jean will share more about that in a moment. So now let me share some of the additional cultural adaptations. Obviously, the California Rural Indian Health Board product, Second Wind, is developed for Native folks. So we really wanted to just add some extra pieces that we thought would work for our community. Again, that frame around traditional versus commercial tobacco and that search for and relationship with the sacred. Again, really highlighting our historical traditional tobacco relationship and really about respecting protocol and bringing folks to use that knowledge that's been passed down in their relationship to their addiction to commercial tobacco. We use pan-tribal stories and some local stories to share that with our community members within the group level intervention. There's a great product from the Tobacco Education Clearinghouse of California. They have a specific American Indian section on their website. This is also in your resource page. And there's a really nice, well-done booklet on traditional tobacco stories, and then there's several Native-specific booklets, you know, for client handouts. We always had fresh live tobacco in the sessions with us. That was from Jean's garden. You know, we had it fresh, we had it dried. We wanted it to really have a presence in the classes, and of course sage and angelica root for smudging, and also just to have that presence. We made sure to have medicinal tea and healthy snacks. I think again it was bringing people back to some connection with the earth. As well, we focused the first session with a talking circle and really trying to keep a Native orientation from the beginning, and again sharing that traditional relationship with tobacco and also with Native identity, sharing really the high rates of commercial tobacco, helping people orient to that reality and how much of a norm it's been for many of us and our families, sharing really some of the first memories we have with smoke for medicine or smoke for commercial tobacco. We added the mindfulness meditation, again, to connect with breath, with breathing, with the body, with that sacred space and spiritual space, using breathing practices, guided relaxation, and visualization. And then we also offered in your handouts for the webinar our closing ceremony, which we had created in order to support group members to make offerings, often paraphernalia related to their commercial tobacco use or some connected item. So making offerings and then sharing our shifts in identity to a Native non-smoker. And then we've attempted to do an ongoing drop-in for alumni. We did that for some time. I believe it was once a month. That piece was hard to get off the ground, but we really wanted to give a sense of community and really reinforce this new identity through this drop-in group, and obviously to prevent or intervene during relapse. And then meanwhile, our policy was being developed. Pretty typical policy structure. You have this handout as well, but it talks about the purpose, you know, how this came to be, the authority we have to enact the policy, the background around, you know, the problem of commercial tobacco use, you know, first, second, and third-hand smoke. It, you know, gives guidelines on the prohibition. Talks about traditional tobacco. We want to make sure that was in the policy, and then compliance, and then the policy implementation procedure. Of course, there's a bit about penalty if staff are smoking on campus. But then we wanted, so obviously we wanted that, you know, basic structure. We wanted to focus with a long-term shift to be a complete smoke-free campus. So we had for several months an interim designated smoking area. We had a special opening ceremony. We did have 2 of these areas, one for staff and one for patients, clients. And so we believed that would be that steady, slow and steady process. So people really got quickly socialized and oriented to use those spaces, and then eventually moving towards a completely smoke-free campus. Again, with information being shared with the community throughout the process. And we did have signage. I thought that was a nice touch with, it was the interim signage that had the, you know, asking folks to use the designated areas. And I believe that it had a phrase, protect our people, and it had a tribal image that I thought was, it softened the ask for sure. I think by the time the policy came out and we had the interim designated smoking areas, really it was all positive support we had for the project. There was only in the very beginning kind of a slight grumbling from some smokers, yet they seemed to see this coming. It was obviously going to come down at some point, and they really couldn't deny the importance of protecting the children and seniors, which again was the frame. And most of our tribes aren't particularly isolated, so members, you know, have a sense that it's an important health issue, even if they don't practice it, hadn't been practicing it at that point. They knew that there were risks, and so we didn't have as much struggle with maybe folks not knowing that information. And then I'll share some reflection to this point. Obviously, the most difficult challenge is always the recruitment and retention. You know, often our community members aren't socialized towards a group intervention. I think there's a lot of trust issues around confidentiality that, as you know, most of your clinics, you know, have pulled out of and really healed those issues, you know, between clinic staff and community members and feeling that there's been confidentiality breaches. Also, folks have confidentialities with each other. You know, we're really connected and close community, so people have long-term relationships, and I think sometimes those can be complicated and folks don't feel like sharing themselves. And again, you know, of course, the value of modesty, you know, around sharing your inner world and your struggles, that definitely inhibits people. And I think lack of successful experiences, you know, negative childhood school experiences often related to racism and related and really kind of expected dynamics, being told how to live when you come to a group situation, or even when you come to a clinic visit, a one-on-one clinic visit. You know, people fear they'll be put upon, you know, be told what choices to make. I always thought it was interesting that our Red Road 12-step members, and also folks often with diabetes and prediabetes, where we offer a lot of group level interventions, they were fully oriented to this group process. They really already bought into the benefits of a group experience, and they did really well from the beginning. And so we tried to remedy these challenges, of course, reminding people not that they didn't have to quit at the first session. In the group level curriculum, it's several sessions in before you quit, and as well during individual sessions in our medical department, that they don't need to quit when they show up. We did a lot of reminder calls and gave a lot of individual attention before and after group to really try to connect people to us and help them feel comfortable and very welcomed. We offered several native giveaways that, you know, perked people up and kept them coming. And we had a really great, took the time to create a wonderful offering of snacks and different things they can use for triggers. And I think people really appreciated those gifts. And, you know, snacks during the sessions. We did create, as we went, a solid process of referral from the medical department. So really specific referral form with ongoing staff training to use the form and a lot of reminders about the new process. I think recruitment will be easier as we start our group level classes again, now that there's a background structure that exists in terms of assessment of commercial tobacco and counseling that Jean will be sharing with you, that's very consistent. Another challenge was a lack of support, and I realize it's a lack of support asked by those of us involved with the project. I found we just added all this tobacco work over several years onto our plates, already full plates, without asking for set-aside time to plan and implement. I think this led to tasks just falling on a few people and causing the project to not be quite as grand as it could have, or really institutionalized as it could have, as we would have preferred. You know, we were, you know, writing mini grants for the giveaways, meeting at lunchtime. You know how that goes. And so I think as we move forward, really asking for more space and time to institutionalize the group level intervention more so. And now Jean will share with us more about medical department intervention and protocols that she's worked with them to develop.
Hi. So as Alison mentioned earlier, it became pretty evident that our medical department didn't address or document tobacco use of clients consistently. So I'm going to discuss the development and implementation of our cessation program and sort of what our process was. The framework of our medical department is a patient-centered medical home. So in this model, they have a designated provider, designated registered nurse and medical assistant, even designated receptionist. So they have a team of people that consistently work with them with the goal of meeting them where they are to support them in their health journey. And we feel each person has a unique relationship to tobacco and needs an individual plan and process for quitting. So how do we do this? Well, one of the tools that has really helped us the last couple years is our electronic record. And it's not without its challenges. This is one of our medical assistants here. It's great for tracking information. It's great for having reminders pop up, like our tobacco screening reminder comes right up on the screen in the visit. It makes data retrieval much more accessible. But problem areas are making sure the data is really entered correctly. Sometimes there's so many clicks that you can actually do something and maybe didn't click the right box. And then also really being present with the client when you're typing on a computer. And that's been a major challenge and change in our practice for many of us. Another tool that we use in the tobacco cessation is the 5 A's, and Alison talked a little bit about this earlier. It was developed by the United States Public Health Service and is a best practice guideline in the resource guide under treating tobacco use and dependence, which is in your resource list. So the basic process is to ask about current smoking status at every visit, then to advise them to quit and provide information on how beneficial quitting is, to assess their willingness to quit, and assist with finding resources and making a plan and arranging for referrals and follow-ups. So we try to incorporate all 5 of these steps in our practice. So I think one of the things that we do here that has made a tremendous difference is that our medical assistants are really at the center of our cessation process and the key to our program working. When they're rooming a patient and taking vital signs, asking about pain level, which is considered the 5th vital sign, they also screen for tobacco, alcohol, depression, and domestic violence at every visit. So I call it the 6th vital sign because it really does impact someone's well-being. So commercial tobacco usage screening is done for everyone age 5 and up, and that's actually a GPR requirement, Government Performance Results Act. And secondhand screening is done for everyone at every visit beginning at birth. If they have a history of smoking, that is addressed as well. After the patient gives their chief complaint, the medical assistant may say, now I'm going to ask you some questions about things that may be affecting your health as a lead-in to the screening questions. So this was actually a major change for us, and initially some medical assistants felt very uncomfortable asking such personal questions, especially with the issue of relatives being patients. It's a pretty tight community. The medical assistant might be an aunt or an uncle. But with in-services and practices, they became much more comfortable. And also, because it happens at every visit now, the patients have become more accustomed to it as well, and so now it's just part of the routine practice. And this has probably been one of the major changes. So it's just they're screened before the provider even goes in the room. So this is just a copy of our screening questions that are in our electronic health record. They help to walk the medical assistant through the questions about commercial tobacco usage, whether they smoke or use smokeless, chew tobacco, their history of tobacco, and education and resources and referrals provided. If they quit in the last 6 months, they're considered cessation smokers, and there's also a box indicating that education encouragement was provided to them, which is also a GPR requirement. And it is really important because most people relapse in the first 6 months, so it's really important to provide that education support during that time period. And then under history of tobacco, they can write how much they smoked, for how many years, and when they quit. And this is our secondhand smoke screening tool, and that is begun at birth. And also, there's a place for, you can click if you gave education. So every client with a positive response for commercial tobacco usage or secondhand smoke is given brief education about the hazards of smoking and offered resources for quitting. If they've quit, they're asked when, and again, if it was less than 6 months, they're given education and resources. We keep written materials on quitting smoking and secondhand smoke in every patient room, so it's really easy to hand out resources. And then the medical assistant lets them know about the quit line and or cessation counseling resources in our clinic. So next, the provider, once the patient's room, the medical assistant does a 30-second review with the provider about why the patient is here, and at that time they'll let the provider know about any positive screening. So the provider can provide further information, support, order pharmaceuticals, or more referrals if needed. So I'm just going to sort of talk about everybody's role in the team. The registered nurse's role in our clinic is really case management and health education, among other responsibilities. And most of our nurses have areas of expertise, such as prenatal care, wound care, or diabetes. And one of the nurses is the tobacco educator, and that's me. And so when a provider or a medical assistant refers them, I can do 45-minute face-to-face appointments and follow-up until they've gone 6 months without smoking. And the number of sessions is really individualized based on the patient. And if I'm not in the middle of something else, if they have someone right then, I can come in and sometimes do a 5-minute face-to-face, so they meet me. Let them know they don't have to quit the first time they come. I'd say that is such a major barrier. People think when they walk through the door they've just had their last cigarette, and I really try to help them realize this is a process, and we're here to support them on that journey. So sometimes during counseling, bigger issues arise, like not feeling worthy of good health, or penance for something they've done, or just really it's hard to be alone with themselves. And how do people fill up the empty space that tobacco has filled? Because tobacco literally fills up the empty spaces of our lungs. And how do we deal with boredom or grief or letting go of something that was always there? And it can be like ending a long-term relationship. There can be grief, even if it was a destructive one. So there are times when it's helpful to send someone to a clinical social worker, and this is Alison actually, who sent people to, and also have worked closely with the behavioral health department with clients who have mental illnesses, because we really want to support them getting off tobacco. Everybody deserves to be tobacco-free, and sometimes it takes a little more support. We also have a pharmacy here, and we're really fortunate with that. And in that 2008 public task force that I talked about earlier, they said pharmacotherapy doubles the quit rate and should be offered to every smoker who desires to quit. A combination of behavioral treatment with pharmacotherapy is the best evidence-based treatment for tobacco dependence. So we're very fortunate we have a pharmacy on site, and I'm just going to talk a little bit about medication. That could be a whole hour talk in itself. But we have the three main types of FDA-approved medication, which is nicotine replacement therapy, bupropion, and varenicline. And of course, not all insurances cover all of these. But one of the things, if a patient says that a medication didn't work in the past, my first question is, how did you use it? Because I said lots of times people don't actually use their medication correctly. So someone who says, oh, the patch didn't work, it really may work for them when used correctly. And since nicotine replacement therapy is the one that's most commonly used, and it really partially replaces nicotine that they formerly got from tobacco without carcinogens. And that started on the quit date. One of the two main things I've learned about nicotine replacement therapy is it's really important not to underdose or give medication for too short a time. So someone who smokes 2 packs a day may need 2 21-milligram patches, and often there's a hesitancy to adequately dose. And the other thing that's really important is not to decrease the dose before they're ready. I think people think, okay, 4 to 6 weeks of this, then 2 weeks step down, 2 weeks step down, and you're done. But someone who smoked for 40 or 50 years really may need that nicotine replacement therapy longer. And so the criteria I usually use is, when do you feel confident and comfortable in a trigger situation? And then that's the time to step it down. And another point with nicotine replacement therapy, it's sort of like asthma medicines where you have a maintenance med and a rescue med. So you might be on the patch and then 1 or 2 times a day need nicotine gum. So just wanted to mention that. And then let me just, so I also want to mention we have an integrative health provider here, and clients can make an appointment with them, and this doctor provides herbal and nutritional supplements to really support the body in healing and during and after the quit process, and talks about diet, exercise, nutritional supplements, deep breathing, guided imagery, because there's a lot of healing that goes on once you quit tobacco. So the other part of the team, last but not least, is our IT person. And Heidi's been really, really important for creating the screening tools, being sure they actually meet the GPRA guidelines, being sure that the information is documented properly and populating correctly, running reports, and helping to identify areas that need attention. So she's just been a great part of the process. So I want to talk a little bit about the counseling process itself to provide education and support for clients. We sort of give patients 2 options. We have a California helpline. I think there's a national helpline, and a lot of states have helplines. And that counseling is available 7 days a week on the phone, and they also provide free nicotine patches. And in California, they've had training in cultural sensitivity with American Indians. And then we have a counselor on site, who's me, and I act as a liaison between the patient and the provider in the pharmacy. I do 45-minute sessions and then follow up by phone or additional sessions as is needed. So we use the Transtheoretical model for intentional behavioral change, and people move through these series of stages. Pre-contemplation, where they have no intention of quitting. Contemplation in the next 6 months. Preparation is getting ready. Action is from the time they've quit till up to 6 months. And then maintenance more than 6 months. And we hope not relapse, but it does happen. I think most recent studies say that people take 7 to 12 attempts before they finally quit for good. So it's just realistic to think about that. But one of the things I think that happens by our screening for tobacco every visit is sometimes we get clients to think about it, and they might move up in these stages a little more quickly. So also in our counseling, we talk about 3 levels of addiction. We talk about the physical addiction, which has to do with, the receptors in our brain and the desire for nicotine. We talk about psychological addiction, which is habit, because so much of our life is habit, and how to replace a detrimental habit, with one that's positive to your health. And then we also talk about the social aspect of smoking, where it can really help with creating relationship and intimacy, and how to find that intimacy in other ways. So we all know about things that we could do to enhance our health, but change can be really hard. So exploring and enhancing motivation for stopping commercial tobacco is really important with the client. We ask questions like, how important is it to you to quit? What's motivating you to quit now? Often it's children or health or grandchildren or the expense. And how confident are you in your ability to quit? Because we want to increase their sense of self-efficacy. Or what would they imagine their life would be like as a non-smoker? So we carefully elicit the values, assumptions, fears, expectations, and hopes of the client, and help to support their desire for change. So open-ended questions with the counselor providing affirmations, reflections, and summaries. And people often resist what is forced upon them and tend to support what they help to create. So we're really trying to help them create their desire for change and help them to be motivated. So the second step is a really thorough assessment. I love this slide, as it's really about being present with a person as they share their story. How much do they smoke? What strengths do they have that can help them to succeed? Have they quit other substances like alcohol or drugs? And what are the major stressors in their life or barriers to quitting? Previous quit attempts, previous relapse, and what can be learned from that previous relapse? And what coping skills have helped them in the past? And I'd say specifically doing counseling with the Native community, it's really important to allow for silence and time for someone to respond, and to also really listen to the stories, because there's a lot of messages reflected in the story. So the third step is supporting the client in developing their own plans, goals, solutions. Offer guidance by saying, would you like a suggestion for dealing with this that has worked for others? But for the most part, really help them develop their plan for how they're going to deal with triggers. And I know it's a really good session if I'm not doing most of the talking. Each individual is different with different triggers and brings a different life story. So you might ask, what are your favorite times to smoke? What could you do instead? It's actually a tremendous opportunity for growth. Sometimes I ask people, what have you always wondered about or been interested in? Because all of a sudden you're going to have some time. So replace a habit that's destructive with one that supports the health of the individual. Some people take up writing, drawing, instruments like a harmonica, which keeps their hands and mouth occupied. So the old trigger can actually become a trigger for growth. Treatment plans should include a quit date, plan for dealing with triggers, stress management, medication, and follow-up. So I really see quitting commercial tobacco as a journey from being a smoker to a non-smoker. It's really a change in identity, and it's important to take time to think about specific reasons for quitting, and writing them gives motivation for the journey. I think of the medications not as doing it for them, but it's like you put it in your suitcase to help you on the journey. But they're the ones taking the journey, and so every day they got to wake up and say, I'm a non-smoker, I choose not to smoke today. Sometimes we stumble, relapse, but we get back up and continue on the journey to be commercial tobacco free. Oh, wrong way. The first 6 months are really very vulnerable time for relapse. I think I said earlier the average smoker quits 7 to 12 times before quitting for good. So follow-up is important for the first 6 months. I like to ask people when they come in their post-quit sessions, what do they notice is different to reinforce their positive effects of quitting? Food usually tastes better. It's usually easier to breathe. They can move easier. Their family's so excited. They notice they don't smell like smoke anymore. So just try to focus on the benefit. So I just want to do one more slide, and this is, we covered some of the highlights of our program. This slide is based on the GIPRA measurements for tobacco cessation. The dark blue line is the GIPRA target, and the light blue line is patients who've received counseling or quit, and you can see we've had a gradual upward trend since we started working on this. Our goal, of course, is 100%. It shouldn't be 70%, but we're not quite there, but we are working on it. So you can just sort of see over the years from 2009 to 2015 the rise. And so that is our presentation. Yeah, if people have any questions. And then how do we close this so we can see? Oh, hold on.
All right. Yeah, if there's any questions, enter them in the question box on the right-hand side of the screen. Oh, we have a question. How do you bill for your time counseling?
So that's a good question. When we were doing the group classes, which we actually are not doing right now, we would have a provider come in once early on to talk about medications, and then once later to assess, and then they could bill for those visits, and we would do the vitals. With the individual at this point, we are not billing, but there are ways to do it, and we're actually working on that. And I think if you write incident to a referral, some insurances will cover that, like incident to a referral for smoking cessation from a specific provider, and sometimes it's considered like an additional part of that visit, and they will bill. But at this point, we are not. So it's just considered part of my nursing job.
Thank you. Wait to see if any more questions come up. The next 30 seconds to a minute here. We have right here. Do you feel that the health campaigns used are helpful? Do people pay attention to flyers and posters, etc., for the smoke-free policy?
I've tended to think that conversations have more of an impact, yeah, than anything that we put down on a board or something down in the lobby. So I think those lobby screenings, being able to pass out information, even if folks don't want to stop and have the conversation, that they're not just picking it up from a pile, but they're seeing something happening. Obviously, doing giveaways during the lobby is a great conversation starter, just to get all your information out there. We're able to give health information, give traditional information about tobacco, kind of insert our upcoming policy and really prep people that way. So I think anytime you can be in the lobby, obviously it's staff time that isn't billable. So looking at what staff and what programs can do that that aren't dependent on being billable, but also this is what it takes to affect change. It isn't always a billable experience. So I think actually being down there, I noticed too, having different folks down at the lobby events, people that know people, that can easily have those conversations that will attract more interest, and they kind of get it hyped up is helpful. Do you want to add to that?
Yeah, I mean, I would agree that conversation is very important, and I think especially in this kind of clinic, because so many people are related, and it just seems like it can have a real big impact when the story spreads within families.
And I think having Jean in medical, she can do the warm handoff, so it's not just if it's a medical provider, primary care provider visit, that they actually can meet the person that they'd be connecting with, rather than just giving her name, asking the front desk, to make an appointment, and having a pamphlet, to get to meet Jean. I think often they'll know Jean, but they won't, so they can say, oh, you know Jean, she's Dr. Camarada's nurse, she always brings medicine to every doctor's visit, just to warm it up that way. It has, made people a little more interested, depending where they are at around their change process, to come and see her in the individual, and as well as the group level. If a doctor knows that they can make a connection with us, obviously that will be helpful.
Thank you. We have a question regarding how you, or if you, deal with chewing tobacco and other smokeless tobaccos.
Okay, so I do deal with chewing tobacco, and actually California Rural Indian Health Board has some great information about that. And in terms, so that I would treat the same way in terms of doing our counseling. And then were you wondering what was the other thing? Chew and?
Oh, other smokeless forms of tobacco, I guess.
So it's interesting with the e-cigarettes. I will definitely work with somebody on that, but in terms of our questionnaire, this is sort of an issue on our screening questions, because at this point the GIPR requirement is for commercial tobacco, and so that's really what we're measuring. But sometimes people will write in, they want to get off e-cigarettes, and I'm happy to meet with them for that. So we treat it pretty similar, but what we're actually measuring in our screening questions at this point is the commercial tobacco.
Okay. Do you use the quit lines for free NRT? What about use of tobacco coaches at ALA and ACS on phone chat lines?
Yeah, I haven't used the phone chat line. We definitely encourage people to use the 1-800 quit lines. That's fine, and to get the free NRT there. We encourage them to do whatever works for them. Some people are more comfortable coming to someone they know. That's what we're finding here, and those are the ones that we meet with. But we do offer the resources for the 1-800 number. And then our clinic provides the nicotine patches too.
Okay. Here's another question. Here in Florida, we have several hotels on the reservations where cigarettes are sold. How do I handle that issue when trying to do cessation in the community?
It's tough. Do you want to go ahead? Well, and we have casinos too.
Yeah, I mean, I think, there's been some work done by Native and non-Native folks at the health department to kind of look at those, for us, the casino spaces, and how to explore the option of smoke-free rooms and spaces. And so that is still in the works, those conversations. I mean, we have access here, everywhere. I don't know. I mean, I know where my family's from, and up kind of more rural areas, that there's access to cheaper products that obviously draw people in. So we, I think Jean and I would love to take this conversation outside the clinic or in a more dynamic way, to look at the issues of clients in our natural environment, and not just here, but we haven't branched out in that area, just supported efforts of some folks that have.
Yeah, but it's a big problem. We have a really, Crib has a really wonderful DVD that shows someone who works at a casino and the change in his health over, I think it's the 5 years he worked at the casino, where all he got was secondhand smoke. And it's a pretty powerful video. So I think what you're bringing up is it's a really big problem, and we haven't solved it, but it's a big problem.
It would be a really interesting place for a Indian clinic to just open the conversation up, you know. I mean, I've heard people talk a bit about their exposure, but I know people are really excited to have employment and really excited to really, you know, bring money into the community. And so how can, you know, that be celebrated and be true, but also look at, just create a space for people to talk about their concern, you know, for you know, the effects it might be on their health as employees.
We have one more question right now, and that's, how do you address smokers that are pregnant and breastfeeding with NRT?
So that's interesting. At our clinic, the providers are not comfortable using NRT with pregnant women. Our public health department has a program, Smoke-Free Babies, and they do use, you know, they use the lowest level NRT that works. I mean, I think the idea with pregnant women, although we don't use NRT here, but from my education, you want to use the lowest level that works. So the lowest level would probably be nicotine replacement gum, you know, and but when I'm working with pregnant women, I try to do it behaviorally. So that's just our provider's policy here. And I also will refer people to Smoke-Free Babies. Oh yeah, I mean, I don't feel like people need to be taken care of here. I want them to get the care they need, and so they can get it here, or they can go to Smoke-Free Babies. And we have someone there who's excellent, and that's just her focus. And I think their philosophy is they're getting nicotine anyway, so they might as well get a steady dose of nicotine without all the other additives as they're in the cessation process. So that sort of reveals, it's, you know, up to the provider's philosophy on that.
Thank you very much. That looks to be the end of our questions. So thank you for attending the National Name Network Technical Assistance webinar. Please watch for the evaluation survey, which will come to you by email shortly. If you're planning to obtain CEUs for this webinar, complete the evaluation survey in its entirety. Please visit our website, www.keepitsacred.org, to find this and other technical assistance webinars, as well as many other cancer and commercial tobacco prevention resources for tribes and tribal organizations. Thank you again. Thank you to our presenters.